very much, Ole, and thank you to the ERAS committee for inviting me for this talk. So we're going to talk about what's relevant to anaesthesia in the past, and I'm going to share with you the future. These are my disclosures. Now, outcomes means different things to different people. For many anaesthetists, we think mortality. You know, you give a new drug if it saves lives. But in fact, this is an important outcome. It's pain. And what about nausea? We have tables of morbidity. Is that something that is really our outcome, or is it the surgeon's outcome? Perhaps return to work. Is that important? And dollars? Anaesthetists have worried less about dollars in the past. Maybe we have to do in the future. And fundamentally, for 20 years, we've been concerned about safety. We get the patient alive at the end of the operation. So you can divide these into two types. I consider hospital, local doctor outcomes, and patient-focused outcomes. And so we've largely in the past looked at surgical outcomes: mortality, morbidity, length of stay, safety. And we've not too bad on pain and satisfaction, but the quality of recovery, and particularly when the patient leaves our care, tends to be an area we have not focused much on at all. Fundamentally, do we really care whether life is better after the operation than it was before? Now, one of the problems with anaesthesia research focusing on mortality and morbidity is that in fact they are mostly negative studies. Not negative studies, no difference shown studies. You need very large studies to do it. And I think we have to be realistic. Does an anaesthetic intervention, is it a big signal or is it a small signal compared to the surgical insult? And in fact, what we find is the majority of anaesthetic interventions might affect mortality or morbidity 10 to 15%. We're actually a small outcome. And a 10 to 15% difference means a very, very large study. You need 8,000 to 10,000 patients to look at that. So, we heard about beta blockers. 10 years ago, we put it in the drinking water because it was so good, and after Poise study, it became the dirty water in one day. And we've just had the Poise 2 data, which have shown that if you give aspirin to patients, there's no cardiac benefit but more bleeding. And if you give clonidine, there's no cardiac benefit, but there's more hypotension and cardiac arrest. So what we've seen from these studies is that we tend to kill the drugs. We're not actually helping a lot. It's a safety thing in a very large population. However, as an anaesthetist, you will never see that signal in your practice. If you have to treat 500 patients to save a life, even your hospital will not see that signal. So where can we make a difference? This is where I think the future for us is going to be. It's about postoperative quality of recovery. Now, why is this important? Well, we take a patient, okay, we operate, patient starts to recovery process, and they've recovered if they return to where they were before or better. That's recovery, okay? And this is a variable path. It can happen early, it can happen late, but we might be able to influence that. And why it is important is that we know that every single one of our patients does not have perfect recovery. So this is an everyday event for all of our patients and our practices. If we actually pay attention to this, we might be able to make a difference well beyond our care time in the operating theatre. There's another fundamental importance here, and this is evolving around the world, is that anaesthetists are changing from intraoperative technicians to perioperative physicians. And the message I can tell you is very clear from around the world. If you ignore this and wish to remain just the technician in the operating room, you will be replaced by one. That's very clear. So part of being the perioperative physician is to be able to measure outcomes after the patient has left your care and be involved in that. Now, one of the problems with recovery is you get a different scorecard depending on who you ask. So this man here, we'll call him Old Bob. And Old Bob had colon surgery. That's a good ERAS operation to have. And in fact, I anaesthetised him. So he's a tough man. He survived my anaesthetic. And I thought, well done, Colin, 10 out of 10. You got him through alive. The trouble is, he was nauseous in the PACU. So the PACU nurse says, no, 8 out of 10. He's not perfect. And then on the way back to the ward, he vomits in the bed. And for all our nurses here, you're probably going to score me 0 right now, okay? Because you have to change all the bedclothes and make him better. But in fact, the nurse gives me 6 out of 10 because she's not happy. And old Bob feels dreadful. I have terrible pain, doctor. I'm nauseous all the time. Terrible operation. 4 out of 10. But worse still, when he goes home, his family say, old Bob is not the same. He's not dressing himself. He's not remembering things. He's not eating. We will have to send him to a nursing home. This is a disaster. Okay? So one of the things that follows on from this is that if we're going to make a difference to quality of recovery, we actually got to measure it. And right now that's a big missing area in many of our practices, is actually measuring quality of recovery after the patient leaves hospital. Now, I'm chair of the PQRS, Postoperative Quality of Recovery Scale, and you'll hear a bit about this in a short while. But it's very aligned to the principles of ERAS. ERAS is all about measuring and improving, and so are we. So it would be quite a good idea to put the two together, wouldn't it? Okay? And that's actually going to happen. We are going to integrate the PQRS into the ERAS system, so we have this added dimension of patient measurement. Now, the tool I represent is the Postoperative Quality of Recovery Scale. And this is a tool we started developing 7 years ago and published in 2010. And we're interested in making a tool that is comprehensive but simple to do. Okay, quite a task. But also one where we can track recovery from the early time period out to weeks and months later. So you can actually see what's happening to your patients. And we define quality of recovery not as a single entity, but as a series of domains. So physiological is important, but it is different from nociception, pain and nausea. That is quite different from cognition. But when you actually have a patient with a problem, you need to know where the problem lies. And that's where you'll look back at the domain to see what is contributing to poor recovery. And we've designed a scale where in hospital, you do it face-to-face, but when the patient goes home, it's all done on the telephone. And that's really important for workflow and labour and getting high compliance rates. So recovery we define as when you have back to baseline or better. Okay? If you're as good as you are before, you have recovered. This is how recovery profiles look between different groups, and I deliberately haven't put what the operation is. I just want to show you that this is the percentage of patients recovered and at different time points out to 3 months. And you'll see different shapes of recovery for each of these 3 different groups. And we can discriminate between the recovery profiles of these 2 groups. Satisfaction. Hands up who thinks satisfaction's a good metric of quality. No one? 1 or 2? Let me tell you that it's a terrible metric of quality. Basically, there are only 2 things that influence satisfaction: pain and nausea. Fix the pain, prevent the nausea, you'll have happy patients. And the problem is that about 85 to 90% of patients are always happy, irrespective of what you do, even if they have poor quality of recovery. And we call this a ceiling effect. It's very hard to get better than good. Okay, so it's not a good discriminatory test. So let me show you a little bit of data from a study of ours published in ACTA Scandinavia about discriminant validation. Can the test actually discriminate between groups or treatments? And so we looked at arthroscopy patients, younger and older, and the same older patients but having knee replacements, same age group having knee replacements. And of course we standardised everything as much as we could. And we thought, well, let's have a look at the minor operation 2 age groups, and then the same age, small operation, big operation. Okay, we had 61 patients in the arthroscopy. We had a smaller number knee replacement because none of our anaesthetists wanted to use general anaesthesia. They were convinced, I think, by spinals. So here's our graph of patients recovered percentage versus post-operative time points. And you can see that our care in Australia is excellent. Physiological recovery, no difference. But look at pain. Pain is on the left, nausea on the right. This is the graph you saw before. Let me show you that the black is older arthroscopies and the red younger arthroscopies and the blue knee replacements. Of course we expect knee replacements not to be better. But one of the snapshots, and when you start measuring you begin to understand depth of data, is look at how many patients actually have recovered at 3 months. It's 50 to 60%. And what that means is that 40 to 50% are actually worse 3 months after surgery than they were before. That's a big problem. That's something that could be looked at and treated. I'll just skip a couple of these for sake of time. But this is cognition. Okay? Note that the knee arthroscopy group was significantly less. So the size of surgery did have an impact on cognition. Now, one of the things about tools like this is you have to make it easy to use. So what we've done as a group is spend a lot of time and effort having a web-based portal to make this easy to use and to report. Okay, if you're interested, that's the website. And as I said before, this is going to be integrated into the ERAS system as well. But I just want to finish with something that I think is incredibly exciting. And that is, can a recovery scale, such as PQRS, actually be an early warning system? What do I mean by that? What I've noticed in doing research with this scale is that around day 1 to day 3, recovery plateaus for most people. Okay? But there is a substantial number who have not recovered at their time points. And what's interesting is if you look at the patients who recover early, you can almost forget them because they do well whatever you do to them. What it means is that if we can actually identify those other patients who have not recovered, then we have an opportunity to intervene and treat and see if we can improve their quality of recovery. And that, of course, has major impact both on patient quality as well as cost. So I think this whole concept of a dynamic measurement system to detect early recovery or failure of early recovery could have a great benefit to all of us in our practices. I just reinforce it's an everyday event for all of us, quality of recovery, and what we might do in the operating room might actually affect patients long after our care has ended. Thank you very much.